Okay.
Yes, sir, you can start the live lesson.
It is actually, please enable the screen sharing. Kindly enable the screen sharing. It's just showing host disable the participant screen sharing.
Uh, Yes, sir, now you can share the screen, sir.
Got it. Thank you.
Mhm.
Okay, so welcome all of you. So these are the topics that we are going to cover up today. Welcome to this exam master live classes, and I'm Dr. Ankit, your anatomy faculty. So in this session, we are going to start the low limb today, and these are all the questions that we are going to cover. To start with, we have going to go with the anterior part of the thigh, then posterior and the middle part of the thigh. So basically, we are going with the region of thigh today. We will see how much we can go, and we'll continue for the further. Then these are the slides over here. You can have a quick look. So these are all the important benefits which you get once you log on to the Auricle. These are all the benefits of Auricle. So in this particular classes, the most important topics are what we are going to cover up, right? So these are the most high important topics. Okay, and it's going to benefit not just for university exams, but if even if you are slightly preparing for your future NEET PG or other competitive exams as well. Core features of Oracle. Here we can see the important core features, live classes as you are already witnessing. We also have recorded lectures, notes, very high yield notes over here, and plus very good quality MCQs are also over there. Few packages, just to remind you, from basic for 3 months to we have standard 6 month package to mentorship, 12-month subscription plan. So there are three subscription plans. For 3 month basic, it goes from 15K to mentorship. We have 50K for a whole year, right? And also you can book a slot for personalized counseling session over here. So these are all the important features. So coming back to the topics, these are all the topics that we are going to cover as already discussed. So let's start over here, right? Okay. So here we start with the thigh over here. So front of thigh is what we are going to start with. And let's move on with it. So there's going to be a quick session, a quick revision. So a thigh is an appendage, like a lower limb is an appendage. So thigh is obviously an appendage. Thigh is a region between the hip joint and your knee joint. So it is the region between knee and hip. That is the region is the thigh where we have the femur bone. Okay. So it will have superficial fascia. Just you can look at just beneath the skin. We have some fatty tissue that is known as a superficial fascia, right? A very thin membranous fascia might also sometimes be seen, but that is actually merged with the deep fascia of the thigh. More important than this, focus more on this topic as the deep fascia. It's given a different name known as fascia lata. Okay, and this deep fascia over here or fascia lata over here, it is acting like a sleeve. Okay, like a sleeve which you can wear on your lower limb or your those leggings which you wear on your lower limb and anything like compression stockings that you wear. So this deep fascia is like that. It is like a sleeve over here. Do remember that term. Okay, so it is going to envelop the whole of the thigh. Now here are a few attachments which are given for the attachments for the our deep fascia or fascia lata. You can even take the screenshot of this, but understand that superiorly it is attached somewhere between the junction of the lower limb and pelvis. And at that area, also do remember that at that area there can be applied part. There is a line known as Holden's line. Okay, by which the deep fascia of the thigh, that is the fascia lata, it is fused with the scarpa's fascia of the abdomen, with the scarpa's fascia of the abdomen. And this is very important clinically. Remember when there is any fluid accumulation in the abdomen, okay, any fluid accumulation, say ascites or liver failure, whatever it is, that fluid does not enter into the lower limb. It is due to this presence of this Holden's line over here, right? So remember the clinical importance of it. Inferiorly, as you see that it goes down into the leg region, into the bony prominence, and this bony prominence basically is around the tibia, around the medial surface of the tibia, anterior medial surface of tibia, and around the capsule of knee joint is what it actually merges with it. Anteriorly, you can see the attachment goes to the inguinal ligament. Behind, you have all those posterior, the lower part of the vertebral column, that is sacrum or the sacrotuberous ligament. On the sides, it is attached to the iliac crest, and medially, it is not medical, it is medial over here. Medially, it is attached to the pubic arch. So it acts like a sleeve, understand, and this whole lower limb is attached to it. Okay, that's very important to understand to begin with the lower limb. Next comes as a question, what are the main modifications of fascia lata? So very, very, very important modification over here. This is the iliotibial tract. Iliotibial tract. Okay. Now break down the name. It is, there are two terms in this name, ilio and tibial. It means that it has something, or it has attachment from the iliac crest, somewhere in the iliac crest, anterior part, and goes up till the bone of the medial bone of the leg, that is tibia. Okay, so it runs through the lateral aspect of the thigh. That is a modification of a deep fascia, fascia lata. You'll understand that it is going from location is at the lateral aspect of the thigh. Now, the length is up till the whole thigh. This 2-inch over here is actually the width. Is actually the width of the fascia lata, and it extends from iliac crest as we discussed, and it goes down into the tibia. So superiorly and inferiorly, you can see the attachments as we discussed. It is going from where, iliac to tibia. Therefore, it is known as iliotibial tract. And do remember that there's also a term which you should know, that is at the tibia where it is attaching, where on the lateral condyle, it develops a tubercle over there, and that tubercle is known as Gerdy's tubercle, Gerdy'. So there's a small tubercle at the tibia where the iliotibial tract is attached, that is known as Gerdy's tubercle. So remember this name is Gerdy's tubercle, right? So whatever these things I'm highlighting, try to highlight or try to do in your theory exam the bold capital letters over there. So this is one thing. Second thing is, are there any muscles attached to it? The answer is yes. Two important muscles, which are the gluteus maximus and tensor fascia lata. These two muscles are attached to the iliotibial tract. Nerve supply of this muscles over here will be the inferior gluteal nerve. For the gluteus maximus, we have the inferior gluteal nerve. Tensor fascia lata will be the superior gluteal nerve. But now the other point which you can write in iliotibial tract will be, what are its functions? Okay, functions. So these two functions, remember, it is basically meant for stabilizing the knee joint and the hip joint. Basically, it is a modification of humans becoming bipedal organs, right? We were quadrupeds and then we became bipeds. So we need a prolonged standing. For prolonged standing, the muscles in the lower limb are basically our voluntary muscles, so they can easily fatigue with the time. So to prevent that and to aid in the bipedalism, this is a modification of deep fascia, that is iliotibial tract on the lateral aspect. So that can prolongly, we can stand like jobs like say a surgeon or for a medical field or a traffic policeman or any job like that where you have to stand for hours. This iliotibial tract is going to help a lot. So remember that point. So if the question comes, short question might come. So define the iliotibial tract, name its attachments from where to where it is going, name the muscles which are inserted into it, and tell the role of the iliotibial tract. This is how you can answer. Now, there's one more modification of the facial lata which can be asked, is your saphenous opening. Saphenous opening is nothing but, see what happens is in lower limb, the veins are more important than the arteries clinically. The reason is the artery will take the blood from heart to the lower limb. So it is the gravity is aiding the flow of blood in the arteries. But for the venous return, the gravity is actually resisting the venous return, right? So therefore, the problem of the pathologies or the clinical situations for the venous part of the lower limb, they are more important. Therefore, in lower limb, we have a group of deep veins, we have a group of superficial veins, as we had in upper limb as well. Now, what happens? We all know that superficial veins finally will drain to deep veins. In superficial veins, we have very important vein known as saphenous vein, right? And that there is a bigger saphenous vein known as the great saphenous vein. This great saphenous vein, mind you, is the longest superficial vein in our whole body. It's the longest superficial vein in the whole body. Now, when this great saphenous vein enters into the deep vein over here will be the femoral vein. Then it has to traverse through an opening of a deep fascia. That is known as saphenous opening. Now, how to correlate it? Remember, you can correlate it in upper limb. When in upper limb, we studied a superficial vein known as cephalic vein. right? There was a basilic vein, there was a cephalic vein. That cephalic vein had to enter into axillary vein. Axillary was a deep vein, and it pierced a fascia. If you recall, then what was the name of that fascia which it pierced? It pierced the clavipectoral fascia. I'm writing over here, clavipectoral fascia. That is the importance of this fascia. And in case of lower limb, here we are discussing the saphenous opening. So first of all, we should understand that what is saphenous opening and what is passing through it. That is most important. Then comes the theory part, which you can easily answer. So it's an oval opening in the fascia lata. Where it is located, that location is very important. It is 4 centimeters below and lateral to the pubic tubercle. Now, where to exactly find it? See, what happens is, if you look at the iliac crest, then let me see. Yeah, this way you can explain. This is an iliac crest over here, right? This will be the anterior superior iliac spine. Then what we have on the sides, on the center over here, we have a pubic symphysis. This will be the pubic symphysis. Okay, pubic symphysis is a secondary cartilaginous joint, midline anteriorly. Then at the top of pubic symphysis, if you go a bit laterally, you feel a tubercle over here that can be actually felt actually. This tubercle is known as pubic tubercle. This is the pubic tubercle. So now the location of the saphenous opening is 4 centimeters below and lateral to the pubic tubercle. So the saphenous opening will be somewhat over here. This will be the location of the saphenous opening, 4 centimeters below and lateral to pubic tubercle. And you can actually palpate the pubic tubercle. So you can actually roughly reach the point of saphenous opening. Okay, practically understand where can we reach it. Now, so this is the location. So somehow you reached the location of the saphenous opening. The length of the opening is around 2 to 2.5 centimeter. That is fine. Now it has two margins, saphenous opening, that you can add. Just go with lateral margin and medial margin. Just say lateral margin is more well defined and medial margin is ill defined. That much is sufficient. You just name that there are two margins, lateral and medial. Lateral is well defined, medial margin is sort of ill defined. Then margins are actually also closed by a fascia known as cribriform fascia. Okay, so this word you can add over here. That opening is closed by cribriform fascia. That is actually a modification of some superficial fascia over here. So remember the term cribriform. Cribriform technically means what? Technically, it is like that sieve-like structure, no? Sieve-like structure which we use in our kitchens normally. Sieve-like structure. That is actually the meaning of cribriform. Okay, then we can draw a diagram showing the saphenous opening over here. There's a saphenous opening over here. Okay, and finally, these are the things which you can tell in the saphenous opening. So if we just revise this saphenous opening, location is important. What it is helping to traverse, it is actually helping to for the great saphenous vein to ultimately drain into femoral vein. The length breadth is around 2 to 2.5 centimeter. Medial margin is ill-defined, lateral margin is sort of well-defined. And also don't forget to add a cribriform fascia. This question can come in around 2 marks question. The small diagram will aid you. Now coming to the intermuscular septa, this is, can correct it. This is intermuscular septa, right? Intermuscular. This is intermuscular septa. So we have how many compartments in thigh? So just to revise it, see, thigh is different from the arm over here. The reason is, if you look at the lower limb and the upper limb, right? Sort of they're both appendages. The difference is that the lower limb is actually carrying the entire weight of the body while you are walking, running, whatever you're doing, right? So it's helping locomotion all the time. Upper limb is for doing the activities with your hands and arm. So if you look at the bulk of the muscles in the lower limb, they are quite bigger compared to the upper limb. This is the reason that in the lower limb, if you look at the thigh or if you look at the leg, all both these areas, you will find three compartments. While in case of upper limb, if you remember, arm, forearm had two compartments. One thing remember, right? So coming back to the thigh will have three compartments, namely anterior compartment. Then we have a medial compartment, and then we have a posterior compartment, simple as that. So we'll look at these three compartments. Anterior compartment is present anteriorly, and it is also known as the extensor compartment. Extensor, it will extend the knee. Medial compartment will adduct the limb, so known as adductor compartment. It's going to bring the lower limb together, close to midline. And posterior compartment are famously known as hamstring muscles, which you see a lot if you watch soccer or leagues. You'll see a lot of football players having that hamstring injuries. Even in cricket, you see a lot of hamstring injuries for the athletes. So these are the posterior compartment muscles, hamstrings. What they basically do is, let's see a function of them. They will basically flex the knee. Extensor compartment, the anterior will be extending the knee. It will basically extend the knee joint. Knee, I mean the knee area, the knee region, the knee joint. And medial adductor is going to adduct the whole lower limb at one. This basic idea you should know. Let me just highlight it. Repeat. In thigh, we have 3 compartments, same as in leg, but the name of compartments are a bit different in leg. In thigh, we have an anterior, medial, and a posterior compartment. Anterior is in front, the quadriceps femoris. It is also known as extensor because it extends the knee joint. Posterior is the flexor compartment or the hamstring. It flexes the knee. And then we have a medial or the adductor compartment that will adduct the whole lower limb. Just to add one more point over here, finishing the whole this part of the discussion of the compartments. Do remember one more thing. What is that? That this anterior compartment, the major nerve for the anterior compartment is going to be the femoral nerve. Femoral nerve. That's going to be the major nerve. For the posterior compartment, the major nerve is the tibial part of sciatic nerve. Tibial nerve, it's a branch of sciatic nerve. And for the medial compartment, the main nerve is which one? I'm sure you guys must be knowing. It is the obturator nerve. Obturator nerve. Okay, so these are the 3 basic compartments and their nerves over here. Okay, let me tell you mnemonic over here also. It might help you. The mnemonic over here is the map of, say, Sikkim. Map of Sikkim. S. Just write MAP, map OFF Sikkim. What is this? Let us complete it. This is a medial compartment. O is obturator nerve. This is A is for anterior compartment. F is femoral nerve. P is the posterior compartment, and this S is a sciatic nerve. Main nerve inside is a tibial. This might help you, and just remembering the compartments and their nerve supply. Now, all of these 3 compartments will be divided by the intermuscular septa that you can see in this diagram also. I'm sure you can recognize this bone over here. It's a femur, the bone of the thigh. There are 3 compartments: anterior, posterior, medial. Just have a look which is the thickest or which is the bulkiest compartment is the anterior compartment. Anterior compartment is the bulkiest compartment. Basically, the muscles over here are working anti-gravity, right? So therefore, there is more bulk in the anterior compartment of the thigh. Fair enough. Let's see more. So clinical anatomy of it is that how you're going to test it. See, thus you can write that if you want to examine the abdomen, right? You ask the patient to flex the hip and the knee so that the fascia, the deep fascia of the thigh that is relaxed, and you can easily examine by deep palpation, right, of the abdomen. So the person is lying down supine, right? Lying down supine, or you ask the patient to kindly flex the hip and the knee joint so that you can examine at this area. Because here you have to do a deep palpation sort of, and you have to examine the hepatomegaly, splenomegaly, or all those examination findings that you have to see in the abdomen. That is one important clinical anatomy. Now let us see one compartment over here. So by now we know that there are 3 compartments. So now we are going to start with the anterior compartment of the thigh, right? Remember, was the anterior was the extensor compartment. The nerve over here was the femoral. So in this compartment, what happens is we have in the upper medial part. In the upper medial part, we have very, very important area that is known as femoral triangle. Okay, so let us discuss this femoral triangle. So where it is located in the upper medial part of the thigh, upper medial part. There is a concavity or sort of depression in the upper medial part of thigh. That area is femoral triangle. Okay, it's a depression, as you can see, it's triangular depression. So now what we need to know in femoral triangle, let me tell you beforehand discussing. We need to know exactly where it is found. What are the structures or boundaries of it, right? What is present in the roof of the femoral triangle? What is present in the floor of femoral triangle? Then what is inside the femoral triangle? That is the content of femoral triangle. That's it. Like, for example, in the upper lip, we discuss the cubital fossa. So in that, we discuss the boundaries, roof, floor, and the content. Similarly, over here, femoral triangle. Let us see. So boundaries over here, you have to make the diagrams over here. So boundaries, you can see that it has few boundaries. It has lateral, medial boundary, right? Lateral, you have the sartorius, medial, the adductor longus. Base is present at the superior part. So that is by the inguinal ligament over here. And where these triangle meet, this lower part that is known as the apex. So below, you have the apex over here. So by this, you can start the topic of femoral triangle. Roof is what? Roof is actually close to the skin. So what is present close to the skin always in our body? Common sense over here. Apply logical common sense. We will have skin, we will have superficial fascia. What is there in superficial fascia and skin? Obviously, the cutaneous nerves. Very good. And superficial veins will be there. These are a few things which will obviously be there, and obviously some superficial lymph nodes, or we can call them as inguinal lymph nodes over here. These are things that we will find in the roof part. Let us see then the skin superficial fascia. Below this, you have that deep fascia, where you remember that saphenous opening we discussed, and we had a cryptiform fascia. That is just below the roof part, or you can say the lower part of roof. We have all of this, right? So here you can go through them, take a screenshot of which are the superficial veins and the cutaneous nerves over here. Then what is floor? Floor is actually more, you can say, more deep inside, right? So floor is formed by a few muscles, and let me tell you over here a mnemonic. These are the medial lateral muscles. But if you go from medial to lateral, the muscles you can remember by the mnemonic, that is A double P I, up P, A double P I. It is the content or the muscles found in the floor A double P I. What is A double P I? A is your adductor longus. P over here is pectineus muscle. This two I and P are iliopsoas muscle. So this P is your psoas major muscle, and this I over here is the iliacus muscle. Now, where do you find these muscles? Understand. See, the iliopsoas over here are basically the muscles of posterior abdominal wall, or in the iliac fossa. Pectineus is regarded as a muscle of the medial compartment of the thigh, though it is somewhere between medial and anterior both. Adductor longus is actually entirely a muscle of the medial compartment of the thigh. But do remember that. So these are the muscles found in the floor of femoral triangle. So we dealt with the boundaries, roof and floor. Most important are the contents. So why are we studying this triangle so much in detail? For example, in cubital fossa, the content was MBBR. Here, the content is your femoral artery, femoral vein, covered by femoral sheath. Then you have the femoral nerves and other nerves over here, right? So, see, writing all of this is obviously bit headache. But remember, if you know the diagram, suppose here's a diagram, here's an image over here, right? There's an image over here. Just look at this image. If you look at this image, then you'll understand. If you draw an image in theory, what you have to write, whatever you have drawn in the image, write down them in your theory, simple as that. These are all the, you can see over here. Let me just point out, you can see the vein over here, right? You can see the red color artery, you can see the yellow color nerve over here. These are very, very important. So again, a mnemonic over here is already written over here. These are the structures. If you go from lateral to medial, what this is a mnemonic for the contents of femoral triangle. If you go from lateral to medial, the mnemonic is navel, Navel, Navel. This will help you a lot. There's so much of applied part of this. What is N? N is the femoral nerve. Femoral nerve, if you remember, is the nerve of anterior thigh compartment. A is the femoral artery. Femoral artery, you should know, is a continuation of external iliac artery. V is obviously femoral vein. So now keep a close look. Out of artery vein, which is more medial, it is a vein which is medial. Artery is just lateral to it. Talking of surface marking, let me add over here. This artery, femoral artery, is present at the mid-inguinal point. So you can actually easily palpate it on your own body. Just lie down supine, feel the inguinal ligament, where it is, or the junction of the lower limb and the abdomen. In that area, on each side, right or left, around the midpoint, try to palpate. The moment you feel the pulsation, that artery is a femoral artery. Okay. So you have femoral vein medial to the femoral artery. This E will stand for an empty space, because medial to the vein there's an empty space, which will have this L is for the lymph node, which will have the L is for the lymph node, which are named as lymph nodes of Clocket or something. Remember the mnemonic NAVL. This is what you have to describe over here, as we have seen in the upper part. This is what you can describe, that what are the contents of it: artery, vein, sheath. Now, what is sheath? I'll just tell you. And these are few nerves. So let's first of all understand the sheath, and then we'll come to the nerves part. Okay, fine. So what is sheath over here? If you look at this diagram over here, okay, I'll look at the mnemonic navel. See this artery and vein, what are they? They are coming from above, like external artery and external vein. So what happens is, once you flex the thigh, this artery and vein are going perpendicular then. Okay, so these artery and vein are actually just below the inguinal ligament. So just imagine we have a vessel where so much of blood is flowing continuously while you're awake and sleeping, whatever it is. And then behind that vessel, you have a hip joint, that is femur bone, head of femur. In front of that vessel, you have the inguinal ligament. So you need some protection of that vessel. Yes or no? Both in front and at the back, you have hard structures. So that protection is provided by the femoral sheath, which actually covers the artery, which covers the vein, and which covers this empty space that is actually known as the femoral canal. Let me add over here that this empty space, which is said empty over here, is actually what is known as a femoral canal. That is also an important topic clinically. Why? Because femoral hernia enters through here. Femoral hernia enters through here. So you see femoral sheath is covering artery, vein, and that femoral canal region. Nerve is outside the femoral sheath. Do remember that, right? This is one thing. Second thing over here is what are the other nerves? Other nerves also you can write, like your femoral nerve, main nerve is this. Then you have pectineus. That's a coming from a femoral nerve only. Then you have femoral branch of genitofemoral nerve. It is actually coming from the lumbar plexus, and it is sensory in that femoral triangle area. And finally, you have another nerve coming from the lumbar plexus, that is a cutaneous nerve known as lateral cutaneous nerve of thigh. Now, this nerve is important. This last one, lateral cutaneous nerve of thigh, is important clinically. The reason is that this nerve can be compressed because it is present laterally. It is a lateral cutaneous, so it is present laterally. So literally, we have one more bone, that is your anterior superior iliac spine. So this nerve can be, this compressed between this bone and the muscles. And when this lateral cutaneous nerve thigh is compressed, there's obviously going to be some paresthesia along what? Along the lateral part of thigh, or you can say a pain or paresthesia along the lateral part of thigh. That disease is known as meralgia paresthetica. That disease is known as what? Disease is known as meralgia paresthetica. Very important for your any level of exam. Okay, any level of exam, meralgia paresthetica. This is must know femoral triangle. Questions do come from here. Let us see forward. And yeah, clinical anatomy over here. So stab wounds. This is also important that see what happens the femoral triangle over here, that if I make a triangle again, like this triangle over here, then what is actually happening is this artery is coming like this, okay? And the vein is coming like this. This middle vein is coming like this. Now, both artery and vein are close, very close to each other at the apex of femoral triangle. So see what is written, that stab wounds at the apex of femoral triangle may cut these vessels. Even person may die, guys. Understand? And so where is the apex? Apex is the junction of upper and middle third of thigh medially. So this is the whole thigh. Let me try to make the whole thigh over here. Suppose this is the, just a second. Yeah, this is the, say, right side thigh. Okay, this is the right side thigh over here. So somewhat over here, let me try to mark it up. Somewhat over here, okay, you have this apex of the femoral triangle medially, and junction of upper and middle, or say middle third of thigh. Around the middle third of thigh, you will have that region of apex. And there is deep stab wound. People might die due to exsanguination of blood from both of these vessels. You can understand both of these vessels, they are so important, right? So people might even die from it. That is important clinically. So we have seen the femoral triangle. Now, femoral sheath, as I told, it is covering which structures? It is covering the artery, it is covering the vein, it is covering the femoral canal. These three structures, remember. What it is not covering is the femoral nerve is being not covered by it. Because femoral sheath is a funnel-shaped fascia enclosing the upper 3 to 4 centimeter of femoral vessels. The reason I told you why it is needed. See, in anatomy, why is more important. If you understood why, anatomy becomes a cakewalk. If you understood why, in small things. Now, femoral sheath, let me add an extra point over here. Femoral sheath formation is by the two layers of fascia. What are these fascia? Understand? Anterior layer of the femoral sheath is formed by fascia transversalis. These are also important at any level of exam. And the posterior layer of the femoral sheath, it is formed by fascia iliaca. Which fascia? Fascia iliaca. Okay, so two layers of femoral sheath are formed by this structure. What will there in the femoral sheath? Obviously, if we know the mnemonic NAVEL, and we know that obviously this is the femoral sheath, then we can easily say this lateral compartment is artery. In the middle compartment is the vein. On the middle compartment, we have this femoral canal region. That is what is written: lateral compartment, intermediate, and medial compartment, having femoral canal over. Just an add-on point over here that lateral, we all know femoral artery, but you should also know that along with it runs this sensory nerve known as femoral branch of genitofemoral. It's a sensory nerve. Middle compartment, you have femoral vein, and middle, you have this lymph node of Cloquet or Rosenmuller. It's a deep inguinal lymph node. It's a deep inguinal lymph node. Remember that too. It's a deep inguinal lymph node. right? Okay, yeah, you can make diagrams, obviously, you can make diagrams of the femoral sheath and all. Now, what is femoral canal is a different topic altogether. Why it is so important, guys? The whole hernia, that is the whole femoral hernia, is a hernia which is coming through the femoral canal. Where was femoral canal? In the middle part of the femoral sheath, just middle to the femoral vein was the presence of femoral canal. Therefore, it is so important because, as I told you, hernia. So you should know the shape, size, and all of this. So these are all things that you have to write. How it is shaped, what is the size of it. Two terms you can add over in this question is one is femoral ring and one is femoral septum. These two right. What is femoral ring? Suppose this is the femoral canal. It's an empty space, remember, and it has what? It has just one or max to max two deep inguinal lymph nodes. That's mainly only one is found. This is imagine femoral canal. What is this? This is imagine femoral canal. Now see what happens is at the top part, this part, it's a base or band that is known as what? It is known as femoral ring. And it is actually covered over here. It was covered by what? That is known as femoral septum. So this green color over here will be known as femoral septum. So it's a condensation of extraperitoneal tissue which closes the femoral ring. Okay, so remember above you have the abdomen and below you have the lower limb. And if there somehow the hernia is approaching from above and it comes down, this is femoral hernia. As simple as that. Therefore, you need to know the boundaries of canal. Why we need to know boundaries of canal? Because once the hernia is developed, what is the treatment? You have to go for surgery. You have to ask the patient that please kindly go for surgery. While doing surgery, you should know the boundaries. Simple as that. So remember, canal anatomy, what is femoral ring, femoral septum, and then canal boundaries. Because here you have to no, this if you are going for surgery, a surgeon has to know, or as a medical, you should be knowing. So anteriorly, posteriorly, medial, lateral, four boundaries over here. Anteriorly, we have what? Inguinal ligament. Posteriorly, we have the pectineus. So remember, P for posterior, P for pectineus. Medially, we have the lacunal ligament. It's the continuation of inguinal. And laterally, you have the femoral veins, septum separating it. Okay, we'll go through it. It's an important topic, right? So contents, these are not boundaries, these are the contents. So contents, we have what? Contents, we have this lymph node, and obviously we'll have some lymphatics passing through it. As I told in the beginning, see, what my way of teaching things and making you guys understand is, once you open any topic in anatomy, preparing for any exam, I don't care which exam you're preparing for, say any topic over here, femoral sheath and femoral canal, ask yourself, why am I reading this topic? What is the use of this topic, right? So based on the first important use I said in the beginning was that femoral hernia. So the moment you hear of femoral hernia, you should know, okay, this topic is important. I need to focus on it, right? You can see femoral hernia over here. Then while operating, sometimes you can get an abnormal, this is not obstructive, but obturator artery, right? Some spelling mistakes, don't worry, I will correct it. It is abnormal obturator artery that you might encounter sometimes. It is present on the medial margin and lacunal ligament, and that might be injured while this doing surgeries. That is one thing also you can add. And finally, as I told in the beginning, the meningeal paresthetica. See, it is coming over here. Meningeal paresthetica. Remember, lateral cutaneous nerve thigh. Let me tell you one additional point over here if you want to. This problem normally is seen in young army recruits. Why? Because young army recruits, once they join the NDA, they have to really jog 10, 20 kilometers, maybe more than that daily. So what happens in the beginning of 1 or 2 months, their lower limb muscles, particularly the thigh muscles, they actually hypertrophies. And that muscle, when it hypertrophies, it might compress this nerve against the bone. So in young army recruiters, this problem is normally seen. Okay. So that is one thing. So femoral hernia, as we discussed, femoral hernia is over here. You can make a simple diagram. And inguinal hernias are above the inguinal ligament. Femoral hernia is just below it. These diagrams you can make. So there is the most important part. Now let us see some more femoral artery questions. Might come femoral artery. Beginning, I told you a few things that it's a continuation of which artery? It's a continuation of external artery, where you will see it at the mid-inguinal point. I want you guys, whoever is listening, kindly go and palpate this artery on your own body, both the sides. Okay, and look at the pulsation that they are going in rhythmic or not, and compare it with your or your radial artery as well. So try to do this right. So femoral artery begins at the mid-inguinal point, as we said, goes down, goes where? Up till your apex of femoral triangle. Then it enters into, that is another point, adductor canal. Where it is, if you're worried, let me just tell you. See, suppose we are looking at which side? Right side, right? So this is the right, say, thigh over here, and this is, say, the knee part, patella over here, right? Patella, right side, I'm saying. So lateral and medial, just imagine over here. Now see, This will be our what we say as a femoral triangle, right? And after that, from here you have a small canal region. Canal. It is beneath the sartorius muscle that is known as adductor canal. So what actually happens is, suppose I say over that there's an artery passing, artery goes down, and then it goes behind the knee joint at the popliteal fossa, known as popliteal artery. So this is your adductor canal. So course of femoral artery starts from the midinguinal point, then it reaches the apex, then it goes inside adductor canal. But then as it reaches the popliteal region, then we don't call it femoral artery. At this area behind the knee joint, we'll call it as popliteal artery. So femoral artery is only from midinguinal point to somewhere where it is passing through the adductor hiatus. Because where the adductor canal ends, there's adductor hiatus over here. There's adductor hiatus opening in the adductor magnus muscle. Adductor hiatus is opening in the adductor magnus muscle. So femoral artery is from there to there. So here you can write passes downwards medially in the triangle into canal, then opening in the adductor magnus, as we discussed, continues as popliteal artery, as I told you. Right? Relations you might add anterior, posterior. What you have medially, you have the veins. Laterally, you have the nerve that you can correlate with your anatomy of the femoral triangle. Branches are important, guys. So do remember, it gives 3 superficial, 3 deep branches in the femoral triangle. In the femoral triangle. So in the femoral triangle itself, it gives off around 6 branches. These are the branches that you have to remember their names. For here, understand, these are the 3 superficial branches over here. Superficial epigastric, circumflex iliac, and external pudendal. And deep branches, one is your profunda femoris. Remember profunda brachii artery. This is profunda femoris artery. Then there is a deep external pudendal artery, and there are muscular branches. Obviously, they're going to the your muscles. Now, students normally find difficult to learn the names of these superficial branches. Let me just tell you over here, simple way to remember it. See, again, I'm trying to make the thigh over here. Say the right-sided thigh, okay? And imagine this is the femoral artery that is coming over here. This is the right side thigh, and let us try to make, okay, this is say the left-sided thigh. Now see what happens is, try to understand. One of these branches from one of the superficial branches, I'm focusing on the superficial only, will actually go where it will go superiorly into the abdominal wall. That is known as epigastric artery. Epigastric is where? In the abdomen. One of the branches from here will go to the lateral side. What will they be called as? Circumflex iliac. They are going to iliac crest. And then one of the branches will be going towards the perineum side. That is known as pudendal artery. Pudendal means perineal region, where you have the openings of the urethra and the anal canal, all that. So this way, there are 3 directions which the branches are going. 1 direction, 2 directions, 3 directions, and 1, 2, and 3, you can remember it. So just remember logically where the branches are going. We give them names by looking at where they are actually going. Names are not given initially. Initially, the branches are seen. Where are they going? And according to the location, we name it simple, right? And deep branches over here. So remember their names, and then you can just describe 1 or 2 lines about these arteries. Okay, that will be good. Now, femoral artery is important. Why? Obviously, the clinical anatomy you can write on about the compression. You can compress this artery. Likewise, we discussed in the brachial artery or axillary artery. You can compress them to control and distal bleeding. You can feel the pulsation of femoral artery. Also, over here, let me add, while doing femoral tapping, what is femoral tapping? When you are not able to find any superficial veins in a patient, and your senior has said, okay, take the venous sample, you have to send for sodium, potassium, or LFT, KFT, whatever it is. You're not able to find any superficial veins in the upper limb and all. What to do? You can actually palpate the femoral artery, and then you take your needle and go just medial to femoral artery, where your needle should be just medial to femoral artery perpendicularly. Where? Perpendicularly. Suppose what I mean is there's a femoral artery. Now this is you are palpating. That's why I told you to kindly go and palpate this. This is femoral vein. Now once your finger has palpated this artery of the patient, now take your needle and exactly go just medial to it perpendicularly. Because the finger will be over the artery, so artery will be blocked. The needle will be inside the vein, and there you can take the venous blood. That's such an important and clinical practical use of it. So much of use. Okay, so you can add that. The embalming also, for particularly for me as an anatomy faculty, we have done this for years and years in our departments to embalm the body. We use femoral artery We can use even the carotid arteries, but normally most of the colleges I've seen, they prefer femoral artery. Even carotid is also not that difficult. Femoral artery is used for embalming in your for your cadavers. Okay, endovascular procedures can be done over here, right? Now, there's a question about explain about the profunda femurs. What is profunda femurs? It is the nothing but deep femoral artery. It is the deep femoral artery. Now, here I want to tell you some concepts over here that are worth noting. Okay. See, what is actually happening is we all know that in thigh we have how many compartments? Three compartments. What are those? That is anterior compartment, right? That is medial compartment. That then there is posterior compartment. How many arteries are there? One. Which artery? Femoral artery. So we are saying, okay, the anterior compartment, we have the femoral artery. Fine. Now, if you trace the course of the femoral artery is going where? Medially, where? Into adductor canal. So that artery can easily supply the adductor canal as well. That is in the medial compartment of thigh. But what about this posterior compartment, hamstrings? Try to understand the problem. Who is going to supply the hamstrings area? Artery has to give nutrition to muscles. Muscles can't work without arteries, else there will be necrosis. Remember VIC in upper limb, Walkman's ischemic contracture. Therefore, which artery is going to go posteriorly? You will say, sir, femoral artery goes posteriorly, but where? It goes posteriorly at the knee joint. But I'm talking of the entire posterior thigh region. So what happens is, listen carefully, that this femoral artery is going to give off this profunda femoris artery. And then this profunda femoris artery is going to pierce or perforate the adductor magnus muscles, and it reaches where? The posterior compartment of thigh. So these perforating branches of the profunda femoris are the one which are going to supply the posterior compartment of thigh. I hope you got the point. The point is this over here. Now let's come over here, explain about profunda femoris. Now, if you know the basics, okay, what is happening, then you can easily answer. So it's the largest branch, as profunda brachii was the largest branch of brachial artery. Okay, course you can see over here. See, it arises from femoral artery around 4 centimeter below. Then it passes behind the femoral vessels. See what is happening. It leaves between the adductor longus and brevis, and then it goes between longus and magnus. Fine, look over. This is the important point over here. It pierces the adductor magnus to anastomose with the muscle branches of the popliteal artery. That is, it goes posteriorly and it gives off branches, these perforating branches, guys. This is important. These are supplying the posterior thigh. And then you'll say these are branches. Yes, these are also medial and lateral circumflex femoral. Let me help you in revising. We learned in upper limb that the axillary artery third part gave anterior, posterior what? Circumflex humeral branch. Remember? They are given by the axillary artery third part. They winded around the upper end of humerus, surgical neck of humerus. Similarly, here it will give the medial lateral circumflex femoral artery. It will wind around the upper end of femur, that is the head of femur, and in that, do remember, this is the main artery, medial circumflex femoral, which is going to supply the hip joint. So whenever you read about that avascular necrosis, right, of the hip joint, when there is intertrochanteric fractures or hip joint dislocation, the main artery over there is the main artery that is damaged is medial circumflex femoral. If this artery is damaged, there are very good chances that there will be avascular necrosis of the hip joint. Understand the importance, right? And finally, this profunda femoris will end as the fourth perforating artery. I hope you got the point what I'm trying to convey over here. Branches, we come again. The main branches were what? Main branches were these, this perforating arteries and this medial lateral circumflex femorals. Few points about the circumflex femoral, so we can just go through them. Medial circumflex femoral, it will give up branches. So better we will discuss them while discussing the anastomosis around hip joint. But just you can go with that branches. It gives off acetabular branches. Mainly remember ascending and transverse branches. Supplies head of femur as we discussed. Same goes to the lateral circumflex, goes a bit laterally. It also gives your ascending, transverse, and also descending branches as well, right? So these branches can go and just read or take a screenshot. You can answer them in detail, but that understanding was important. Now coming to the next point over here, that is a femoral vein. See, artery, understand this basic point. When you talk of arteries, guys, arteries are coming, are actually going away from the heart, right? So in low limb, the flow of artery, flow of blood in the artery is from top down. While discussing veins, the opposite will happen. Veins, the flow is this. Okay. Veins of flow is this. So when we discuss artery, we started from the above, that it is formed over here, then it passes over here, then it ends over here. Right? We discuss in artery from proximal to distal. While when we're discussing the vein, we have to go from distal area to proximal area. This is how we are going to discuss the femoral vein. So femoral vein, where it is present, how it starts. See, femoral artery ended at popliteal artery in the popliteal fossa behind the knee. Similarly, behind the knee, we will have popliteal vein in the popliteal fossa, and then that popliteal vein will continue above as femoral. And that femoral vein, once it crosses passes beneath the inguinal ligament into the abdomen, that femoral vein will be known as external iliac. Okay. So let's see. So situation is, it is in the intermediate compartment of the femoral sheath that we already know, that where it is actually located. Oh, just a second. Let me clear it. Yeah. So it is located at the intermediate compartment of the femoral sheath. Begins where, as I told, we have to go from distal to proximal. This is how you are going to write in exam. It's an upward continuation. Popliteal vein terminates like external iliac vein. What are the veins which is it going to receive? So in case of arteries, when you're writing a theory, you have to say the branches of arteries. But in case of veins, what you have to write are the tributaries. So these words, they matter, right? The examiner might look at these words as well. When we talk of veins, we talk of tributaries because they are entering into veins. And the branches of arteries, they are coming out of arteries. And the tributaries are entering into veins. Understand this. So it receives a great saphenous vein. Remember saphenous opening. Other veins which are accompanying the deep branch of femoral artery, then lateral deep medial circumflex femoral vein, and some other descending veins. This you can actually just take a screenshot and write. Right. So femoral vein, you can make a diagram like this. Now in this diagram, there's a catch, or there's an important point. Over here in this diagram, this over here is the, you can see this is the thick part. I'm making 2-3 arrows. This is our femoral vein. Okay. What it received is, let us highlight that. What it received is, don't forget to mention the great saphenous vein. Don't forget to mention the profunda femoris vein. And don't forget to mention these circumflex femoral vein, these two circumflex femoral veins. They are all entering into the femoral vein directly. But now there's a catch which I'm going to tell you, and this might come in your viva, or can be a very good question for your even your future competition exams. Okay, what is that? Is we discussed that femoral artery gave 3 superficial and 3 deep branches, right? 3 superficial, we discussed their direction: epigastric, iliac, pudendal. So while we are discussing the femoral vein, we normally accept that these arteries, these branches of arteries, the corresponding veins should enter. But the catch over here is, as these are superficial arteries, so their corresponding superficial veins, they don't directly enter into deep vein. Where do they enter? They actually enter, first of all, into the great saphenous. From their great saphenous, then they go to the femoral vein. This is what I wanted to highlight over here. It's a bit in depth, but important. So look at these 3 with the green highlighter. I'm marking circumflex iliac, epigastric, and externopudendal. Where are all of them entering? They are all of them entering into this area. What is this area? This is the great saphenous. Okay, so do remember that. Okay, there was a point which I wanted to just add on over here. Now, femoral nerve. Femoral nerve is a nerve of which compartment? Anterior thigh. See, coming back, how to compare upper and lower limb, that helps you in understanding. Upper limb, we discussed brachial plexus. Which plexus? Brachial plexus. Simple as that. Root value was C5 to T1. The plexus in the lower limb will be basically lumbosacral plexus. Okay, lumbosacral plexus. It starts from where? It starts from L1, L2, L3, L4, then L5, S1, 2, 3, like that. So out of this lumbosacral plexus, all the nerves which you study over here, they are coming out of these lumbosacral plexus. Like for example, we in upper limb we discuss radial nerve, median nerve, ulnar nerve. They all were coming from where? They all were coming from the brachial plexus. Similarly over here. So you should know the root value of lumbosacral plexus. That is from L1, L2, L3, L4, L5, S1, S2, S3. Lumbus are more important, and S1, S2, yes, S1, S2, till S3, it's fine. See, the root values are more. Why? Because as I told that lower limb muscles are more. So you need more nerve fibers. So more roots are needed. Out of them, see the femoral nerve and the obturator nerve, they come from L2, L3, L4. Understand this. This is L2, L3, 4, which I'm highlighting over here. L2, L3, L4. Let me write separately over here. It's common for femoral as well as obturator nerve. The difference is that femoral nerve, it will be from the the dorsal division of the primary, the ventral rami, and obturator nerve will be the ventral division of the ventral rami. That's the only difference. Now, if you understood this much, then we can proceed down. So femoral nerve, let us discuss it as a chief nerve of the anterior compartment. We know it's one of the largest branches of brachial plexus. Fair enough. Origin is, it is from the anterior MI, no doubt about it. All the plexuses are anterior MI. I repeat myself, listen one more time. All the plexuses are formed from anterior MI, but it is formed from the dorsal division of anterior. Course, we know it is femoral triangle, passes lateral to femoral artery. Remember the mnemonic navel from lateral to medial. All these branches. Thigh, it passes between iliac and psoas. That can be a good MCQ question. The question will be the structure lying at the iliopsoas groove. Iliopsoas groove. Structure lying at the iliopsoas groove. That is between iliacus and psoas major. The structure lying over there is what? Femoral nerve is the answer. Okay. Then divides into anterior posterior divisions. And then you can just make a flowchart like this. Make a flowchart like this. See, this again looks a bit complicated. Don't worry at all. Understand over here. Let me show you muscles of front of thigh, and just a second. We had that. Don't worry. Okay. Let me discuss over here only. Yes. See, femoral nerve is supplying the anterior side of thigh. A nerve is a mixed nerve. So it will have sensory, motor, as well as some sympathetic fibers. Right? Now see what happens is, remember, the mnemonic can remember is PQS. What is PQS? PQS is the posterior division of the femoral nerve. Will supply Q is quadriceps femoris muscle and gives off cutaneous nerve. Okay, that is known as saphenous nerve. Remember PQS. So in this image, if you know this, then you know L234, the femoral nerve is coming. This is the femoral nerve that is shown in this diagram. This all over here, if I mark it with say green highlight, this is the posterior division. What it is supplying? All the muscles of quadriceps. Has 4 muscles, we should know it. 3 vasta and 1 rectus, and continuing down as saphenous. This is what you should know. Posterior division. What is remaining is by the anterior division, mainly anterior division, remember a muscle sartorius and a few cutaneous nerves over there. That's it. So anterior division is a bit small. Posterior division is huge. And it is supplying quadriceps. So remember PQS. You can remember this PQS. Posterior division, Q for quadriceps femoris. Quadriceps has all these 4 muscles. And S is for the longest. Now, this is also longest. This is the longest, what, cutaneous nerve. We discussed the longest something else. Longest superficial vein in the body. Great saphenous vein. Longest cutaneous nerve in the body. Saphenous vein. Why longest? Because it reaches where? It reaches till your ball of big toe. Big toe. That is the end of your foot. It gives sensory supply to the ball of big toe, and it is coming from where? From the femoral nerve. It is the longest cutaneous nerve in the body. Okay, so do remember this. So remember PQS and good to go. You're good to go. Now, in clinical anatomy, obviously, see anatomy, clinical anatomy, just if you know what this structure is doing, nerve injury to this can lead to paralysis of this, sense deficit of this area, right? There are a lot of other clinical anatomy while doing surgeries over this area. You can have compression of femoral nerve. They can developing of neuromas in this nerve and all that. Okay, now the muscles. Muscles of thigh already, as we discussed in that we have 4 muscles known as quadriceps femoris. Quadriceps. So till now we learned biceps, triceps. Now it is quadriceps. 4 quadriceps, and 1 major muscle over here is sartorius, which is also known as a talar muscle. This can be a sartorius is a very, very important muscle. It comes as a question in itself. 2-3 marks question describes sartorius. So again, origin, insertion, nerve supply, action, applied, bit of diagram, good to go. Sartorius is known as talar muscle because when we sit down on the floor by palti posture, that palti posture is the action of sartorius muscle. So these 2 muscles are main, sartorius and quadriceps. Then one small muscle also, articularis genu, you can add over there. It is basically helping to pull the suprapatellar bursa of knee joint. But yeah, these 2 muscles are must know to answer, right? And then obviously, like all the muscles, origin, insertion, right? Innervation, action, blood supply, you may or may not write. I'm not saying it is very important, but at these 4 points over here, these are important, right? And each word is not important, guys. Each word is not important. No one remembers it. Even I don't remember it. Let me tell you frankly. It is from the upper 1/3 of the anterior surface of the crest below this part and that part. That is not important. But yeah, you should have a good idea in first day if you're giving a first day exam. Okay, at least if you write 70-80%, you have a good idea of making diagrams. But yeah, action and nerve supply should be clear. Origin insertion, one or two words here and there can be tolerated, but action and nerve supply, they are important. And then basic diagram is what you can also make. These are the muscles of the anterior thigh, main muscle I told you. So how you are going to test it? Simply we know the action of a muscle, that this quadriceps is going to extend the knee. So give a resistance and try patient to ask to extend the knee. If he is able to extend, fine. Not, there's some weakness. Another very important, try this psoas abscess. You'll show the diagram as well. This question came in your recent NEET PG exams as well. The question was, let me tell you, for those who are interested, hear it carefully. There was a child which was asked in the exam. A child had a long case of tuberculosis, and he developed a Pott's spine. So, not TB spine, it was Pott's spine developed. And then along with it, there was also swelling. There was a swelling where in the femoral triangle, right? What happens is when there's Pott's spine, vertebrae are involved in TB. TB is an infection, tuberculosis, infection, spine, abscess will develop, cold abscess. And as we discussed that iliacus and psoas are muscles of post-abdominal wall. So that abscess, it actually traveled from the spine, right, through the psoas sheath, and it came down to the insertion of psoas. Now, where we read psoas in femoral triangle? Floor of femoral triangle, the lateral two muscles. So the abscess came down and small swelling was noted. That is psoas abscess, right? Remember this. Then intramuscular injection also in small in kids, small children, infants. Anterolateral, vastus lateralis, you can give the injections, eye injections can be easily given at that area as well. Right? Psoas abscess, this is the diagram over here. So vertebrae infection over here, pus might percolate from here, come down, swelling over here in the femoral triangle region. Okay, that's the important part. Now, and the part over here is the adductor or the hunters or subsartorial canal. Right? We are doing the anterior compartment, right? So, adductor canal, as we discussed initially, that yes, you have the thigh over here, you have the femoral triangle, and middle part, you have the small canal, that is adductor canal. It is covered by sartorius muscle, so we call it as subsartorial canal, and maybe its name of scientists was hunters. So also known as Hunterian canal, right? Adductors canal or Hunterian canal or subsartorial canal. So where it is present, let us see them. So how you are going to answer in the exam? It is intramuscular space, so it is between the muscles on the medial side of the middle third of the thigh, right? Shape is triangle and cross section. Find boundaries. You can see all of these boundaries and all you can only understand once you draw an image. And the recommended image for the adductor canal will be a transverse section. Will be a transverse section of the thigh. So in a transverse section, you can make a femur like this, and over here you can make the small canal. One side you can name the muscles, like you have the vastus medialis on one side, you have the sartorius covering, and behind you have the adductor longus and adductor magnus. This is what you can write. So anterolateral, what we have vastus medialis anterolaterally. Behind what we have adductor longus and magnus, and middle wall or roof, what we have the sartorius over here. So this is the adductor canal. Find where in the medial part of middle third of thigh. And also do remember, here you have the femoral artery, guys. Here you have the femoral vein. Here also you have these nerves like saphenous nerves over here. These are the important contents of very small canal over here. This is what is the applied importance of this particular adductor or subsartorial canal, right? So you can also write 1 marks question for the subsartorial plexus of nerves. Let's take a screenshot. Mainly the medial cutaneous nerve and the anterior region of obturator nerve. This is obturator nerve, some obturator nerve over here, right? Obturator nerve. They are from the plexus, right? But contents, as I already told you, don't forget the contents of 3 major contents over here. Nerve, a femoral artery, vein, and saphenous nerve. Not the entire femoral nerve. Saphenous nerve, remember PQS. This was on the posterior division of the femoral nerve. PQS, S was saphenous nerve, P was posterior division, Q was quadriceps. Okay, fine. So now we come to the medial side of the thigh. We did the anterior side of the thigh. Now see the middle side of the thigh. Middle side of thigh is also known as what? It is also known as the adductor compartment. What is the nerve supply? Map of Sikkim. A adductor compartment, middle adductor, Okay, map of and nerve supply medial side is obturator nerve. Okay, so nerve supply over here, adductor compartment is your obturator nerve. Its root value will be L2, 3, and 4. So adductor medial compartment, and really you have the septums. Again, see muscles. Muscles, let me tell you mnemonic over here. For the medial compartment, if you want to remember the muscles, you can remember it by the mnemonic Goa with 3 A's. Goa with 3 A's. Because what is this Goa with 3 A's? G is for the muscle which is the most medially located, is gracilis muscle. O is your obturator externus, not internus. Obturator internus is in the lateral wall of pelvis. It is in the pelvis. This is obturator externus. And these 3 A's are 3 adductors. So we have adductor longus, we have adductor brevis, and we have adductor magnus. And all of their nerve supply comes from obturator. Root value L2, 3, 4. What is their major action? Adduction of the lower. See, maximum things you know already. Then you can write a posterior of this. So yeah, we can add this. Pectineus is also regarded as sort of hybrid. We can add pectineus also over here. Okay, though it is supplied by both, you can see the femoral obturator. Therefore, I said it can also be called as hybrid or composite muscle, but it has dual nerve supply. Same over here goes for adductor magnus as well. Let me show you adductor magnus. It is also yeah, right over here. Adductor part by obturator nerve and hamstring part by tibial nerve. So this is also your hybrid or composite muscle. Hybrid or composite muscle. Okay, these questions do come to understand this. Rest, you have adductor, 3 adductors, longus brevis magnus, gracilis obturator externus. Simple as that. Goa, you can remember Goa. Goa, a famous holiday destination in our country. Muscles, you can draw diagrams. Points to be noted: to achieve thigh adduction, where the thigh moves towards the body's midline, adductor muscles contact towards origin, which is at pubis, and the insertion is triangular. It goes from pubis and goes into the femur, right? It goes from there to there. Just a second. Okay. Right? So remember this point. Now coming to the obturator nerve. Obturator nerve, few things we already discussed. This will be the final part of this and continue in the next session. So obturator nerve, as we said, it is from L2, 3, 4, right? And this from the anterior MI again, but from the ventral division. That's the only difference. Force relation, see, that's the difference over here. I'll tell you applied part. Understand this before going into any part. See, imagine these are the vertebrae I'm making, right? Lumbar vertebrae. Okay. Now imagine the nerves are coming out L2, 3, 4, right? And they are forming which nerve? They form the nerve over here that is femoral. Okay, so there's a femoral nerve. Then it went down. There's the inguinal ligament. It supplied the anterior thigh. Done. Good. Other nerve over here, if I change a bit of color over here, let's use this blue color, right? Again coming from L2, 3, 4, but this is obturator nerve. But it goes down where? Into the lateral wall of pelvis. Understand? Where it goes into the pelvis region. So obturator nerve, this is the obturator nerve, blue color obturator nerve, but it is going first into the pelvis region. Then what happens? How does it reaches the lower limb? Understand? Here it has an opening. That opening is known as what? Obturator canal in the obturator foramen. So now this nerve passes through this obturator canal, then it goes down to supply the medial part of thigh. So what's the difference? See, the course is very important. Why? The reason why is recently question has come. Let me tell you, and the question can come in the exam as well. That a surgery in the pelvis was done, right? And then there was some muscle spasm seen in the thigh. Which muscles could be go into spasm? If you are doing a surgery in the pelvis, you are removing the say iliac lymph nodes and all, then that surgery might, this might irritate or damage this obturator nerve a bit, and that can lead to spasm of the medial compartment thigh muscles. That you have to understand why the course is so important. Second, let me add one more clinical point over here. You have one more rare condition known as obturator hernia as well. What happens is this obturator canal, actually it's a very small area in the obturator foramen. But hernia may try to enter through this opening as well. And then that hernia might compress, or it will obviously compress the obturator nerve. So in case of obturator hernia also, you have compression of obturator nerve. So obturator nerve can be compressed in case of obturator hernia. It can be damaged. You are doing any surgery instrumentation on the pelvic walls can damage this, basically in the lateral pelvic wall. That is the importance to understand the course of any structure, major structures, not all. Mainly you should know this. See, now let us see the course of it. So upper part, as they said, it lies in the pelvis, as I told you. It passes through the obturator canal. It has an anterior post divisions. Remember, the mnemonic Goa is going to supply all of those muscles. So anterior division is going to supply post divisions. That you can just read it. Okay, so remember these points about the obturator now, which I just told you, right? So you can make now image of it. So try to practice the images, guys, and see. Anatomy theory is very easy. If you go a bit planned, practice images, and then write the whatever you made in an image, try to write them in theory. Okay, so if you know this image, you can write down it is coming from L234, passes through the canal, anti-division supplies this, post-division supplies this, and all that. Okay, so core simulations, testing the adductors again. If you know, you test the adduction of the lower limb against resistance, that is the testing of the adductors. Spastic paraplegia, as I told you, that there can be surgical division of this nerve, right? Reason could be any. Referred pain, yeah, referred pain could be there. See, knee and hip joint, they are supplied by femoral operator nerves. So referred pain can go from knee to hip or hip to knee. So patient complaining of a knee joint pain might have a primary problem in the hip joint and vice versa as well. Why? The reason is the operator nerve and even the femoral nerve as well. Right? They both supply these both joints. Okay. Okay, fair enough, guys. So yes, a bit of MCQs. Let us see that also we can do. Which muscle is the most medial muscle of the adductor compartment? Gracilis, pectineus, adductor magnus, sartorius. Obviously, it is most medial. It is gracilis. Let us see. Accessory operator nerve. This is an extra part. Sometimes there's accessory operator nerve. It supplies the hip joint and might supply the pectineus muscle. Answer will be option A and B. That's a bit the higher side, but yeah. Which is hybrid muscle? I just explained the hybrid muscle. Discuss two, pectineus and adductor magnus at least. Here we have, yes, adductor magnus here. So option B. What is the nerve supply of the hamstring part of the adductor magnus? Hybrid muscle. Hamstring part is a posterior part supplied by tibial part of shative C. Answer given over here A, D, B, C. Let us see if you are correct or not. A, D, B, and C. Perfect. With you guys, even I am answering all these MCQs. Thank you. Okay, so this was the topic, guys, and we'll meet in the session. And thanks for watching, guys. Thanks for watching the session. I hope you liked it. Any query, ask in the comment box. Again, these are all the features of Auricle. Go through subscription plans, and these are exciting plans over here. Do think about them judiciously and try to choose them. Right? We have also a personalized counseling session as well. So that's all on my side. Thank you for your time and thanks for watching. Bye bye and have a nice day. Thank you.